So the next segment is cardiovascular health. So we are very pleased to have one of our own from SUNY Downstate. He's Professor of Medicine, Dr. Clinton D. Brown. He's been around for some time at SUNY Downstate. He's actually an original of Brooklyn, from Brownsville as well. Brownsville? Bed-Stuy. Well, Bed-Stuy, original. It's now Stuyvesant East, all right. The terminology is changing over time. Anyway, Dr. Brown is a full professor of medicine at the College of Medicine, Department of Medicine at SUNY Downstate Medical Center here in Brooklyn. His main interest is nephrology, but he also is one of the very few people who we call lipidologists. In other words, somebody who's certified in lipid metabolism in the United States. Very few people are able to certify in that area. So we are very pleased to have him today to talk about the contribution of lipid abnormalities and the health disparities associated with lipid abnormalities in cardiovascular health. So thank you, Dr. Brown.
Thank you, Dr. Salafu. As I was telling Dr. Levesque, he's from Brownsville, and people from Brownsville, they say never ran, never will. But in Bed-Stuy, we would say Bed-Stuy, do or die. Okay, so I'm going to talk a little bit about genetics, and I hope I'm not contradicting Dr. Levesque very much, but there is a genetic component that I need to talk about in terms of renal disease. So let me just start by showing this very simple slide that showed the African American represents about 13% of the U.S. population, yet we represent 35% of the patients of the individuals with end-stage renal disease. Now, what are the causes of end-stage renal disease? Okay, so the major causes of end-stage renal disease are diabetes mellitus and hypertension. The combination of the two accounts for more than 2/3 of the reasons for having end-stage renal disease. 90% of my patients that I see have both of these abnormalities. So you can consider that end-stage renal disease is very, very prevalent in Brooklyn. But there's another reason for it, and this is the genetic reason. Now, again, I don't mean to contradict Dr. Levesque, but there is a genetic component that may contribute to end-stage renal disease and hypertension in African Americans. Years ago in West Africa, there was a disease called sleeping sickness, which was a fatal disease. And it was caused by an organism known as a trypanosome. That trypanosome was carried by a tsetse fly. And that trypanosome, when infected individuals, they died of sleeping sickness. So over time, the Africans in West Africa evolved and to create a natural mechanism to destroy the trypanosome. So the trypanosome mutated and became more virulent, and man evolved and developed a mechanism that was more efficient. That mechanism or protein is called ApoL1. And as man evolved and had to fight a more virulent trypanosome, it evolved a more efficient way of destroying it, and that is called the ApoL1 variant. So we inherit that from our ancestors from Africa, and so we bring the ApoL1 variants with us to the United States. 20% of African Americans carry at least one allele for ApoL1, but about 7.6 million people, African Americans in the U.S. have, and about 100 million wide, have 2 copies of ApoL1. So ApoL1, if you have 2 copies of ApoL1, that increases your risk of having kidney failure or chronic kidney disease by 7 to 30-fold. So people who are infected with HIV, they have kidney failure, mainly because of ApoL1. People with focal sclerosis also, as well as hypertension. So ApoL1 does predispose African Americans to kidney failure or kidney disease and end-stage renal disease. So I like to show this slide to show in general that the dialysis population compared to the general population in terms of cardiovascular mortality. If you look at individuals who are on dialysis, 20 to 30 years of age, they have a high mortality, which is equivalent to individuals who are about 80 years in the general population. So if you have end-stage renal disease and you're 20 to 30, that's the equivalent to having the death rate for someone who's 80 years old in the general population. So dialysis really predisposes to death from due to dialysis. So, but what is the causes of death in people with end-stage renal disease? The vast majority of the people with end-stage renal disease don't die from kidney failure, because we can replace kidney disease. We can treat that with dialysis or transplantation. The vast majority of people who die from who are end-stage renal disease die from cardiovascular disease, that is heart disease. So I'm showing you here the lipoproteins, the general lipoproteins, because we're sort of in the custom of looking at lipids in terms of cholesterol and triglycerides. And I want to sort of change that dynamic and talk about it this way. I want you to think about it as a lipoprotein problem. In the general population, high cholesterol, which is carried by low-density lipoprotein and all these other lipoproteins, predisposes to heart disease. That is not the case in patients with end-stage renal disease. So what I'm about to tell you, that once you develop end-stage renal disease, you are metabolically very different from the general population. And that, in a sense, makes it difficult to treat heart disease or to prevent it, because it's a different mechanism. The general populations, if you have high LDL cholesterol, that's a risk problem. HDL cholesterol, on the other hand, is cardioprotective. Now, to make a point, we used to say HDL has good cholesterol and LDL has bad cholesterol. Let me ask you a question. Is there good cholesterol and bad cholesterol? It's all cholesterol, right? Okay, so that is the point. And what you'll see with renal disease, it's not a lipid problem, but it's a lipoprotein problem. It's the lipoproteins who lose their function because of uremia as a result of end-stage renal disease. So basically, though, LDL cholesterol, when it's in the general population, it's oxidized, it's engulfed by macrophages, which cause a foam cell, and you develop atherosclerotic plaque. That's in the general population. And in the general population, where HDL has a good effect, it takes excess cholesterol and removes it and brings it to the liver where it can be excreted. However, HDL has several other functions. It not only does it remove excess cholesterol, but it's anti-inflammatory, it's antioxidant, it protects against infections. It also repairs the endothelium. So HDL has many, many good cardioprotective functions. The unfortunate thing is that function is lost in patients with end-stage renal disease. So when your kidneys fail and you develop uremia, what happens to you is several things. You have increased risk of vascular calcifications. There are other processes which I'm going to go over in detail, specifically carbonylation, which is due to increased blood urea nitrogen, oxidation, acidosis, and glycation. Now, these combine to disrupt the functions of lipoproteins. So in terms of glycation, you develop what we call advanced glycation end products that binds to its receptor and which causes inflammation, and that damages the endothelium. The other processes will interfere with the function of lipoproteins and make lipoproteins, all of them, atherogenic, not just LDL, but HDL as well. So when someone is uremic, they begin to lose weight. They undergo a process called protein energy wasting. And protein energy wasting causes a reduction in lean body mass. You lose muscle mass. And that causes inflammation. And then cardiovascular disease are predictors of mortality in end-stage renal disease. So in the general population, we tell people to stay away from eggs, right? Stay away from saturated fat. Stay away from steak. But in the dialysis population, this is the breakfast of champions. They must eat high biologic value protein to prevent the wasting of muscle mass. Remember, they are having high levels of inflammation, so their muscle mass is dwindling. They must eat high biologic value protein. So I tell my patients, if you like eggs, eat them any way you can get it. Cholesterol is not an issue in end-stage renal disease. Most people with end-stage renal disease have either normal or low cholesterol. It's a problem of lipoprotein function that is mediated by alterations of those lipoproteins. So this is, I repeat, the breakfast of champions. So once after a few months of dialysis, patients become stable. They still have issues. They still have metabolic issues. One is carbonylation, oxidation, and glycation. So with those operations, with those mechanisms in hand, what our patients with dialysis, what they undergo basically is atherosclerosis that involves the vessel wall, the subintimal vessel wall, so you get atherosclerotic plaques like you see in the general population, but the mechanism is different. You also generate calcifications in the media or the middle of the medium-sized vessel. This calcification, also known as Mockingbird atherosclerosis, causes the individual to have systolic hypertension. So you have atherosclerosis involving the intimal, which is atherosclerotic plaques, and then you have atherosclerosis involving the media of middle-sized vessels predisposing to hypertension. So what does the lipid-lowering trials, remember I said it's not a lipid issue, and I say that because we look at the trials that have been conducted before. The Aurora trial, 4D Sharp, using very high-level statin drugs, no significant difference in terms of preventing cardiovascular events. So, what is it about end-stage renal disease? And I repeat, the process in general is called post-translation protein modification of LDL and HDL by glycation, oxidation, and carbonylation. These lipoproteins are altered. So, in glycation, usually, you probably hear about this in diabetics mostly, but glucose, when it undergoes many metabolic changes, it forms an advanced glycation end product. That end product can bind to a receptor called RAGE and cause inflammation. It can also bind to proteins and alter the structure and the function of that protein. And that's what happens to lipoproteins. When the lipoprotein is glycated, it no longer functions as a lipoprotein. HDL no longer takes cholesterol from the cells. It becomes a target for atherogenesis. So again, lipoprotein modification, you have oxidized LDL, you can also have carbonylated LDL, and that is a prime target for the macrophage, or the thing that is being picked up in the vessel wall. So again, these lipoproteins are not functioning to deliver cholesterol to the cells necessarily, or to take cholesterol away from the cells. These lipoproteins are now targeted and are picked up by macrophages and participate in atherogenesis. That includes HDL. Oxidation, the same process again. HDL can be oxidized. Once it's oxidized, it no longer functions as an HDL particle that is become particle protective. It becomes atherogenic. Carbonylation is the process by which blood urea nitrogen, urea normally undergoes a transformation into form isocyanate. Isocyanate is a compound that binds to proteins like glycation and does the same thing essentially. It makes that protein dysfunctional, and also it changes it changes the function of that lipoprotein. So when HDL is carbonylated, it doesn't function as HDL. When LDL is carbonylated, it doesn't function. It becomes a target. So here, this slide shows the amount of carbonylated protein compared to a healthy person's, just about twice as much. So this is the guy, the macrophage, takes up all the altered lipoproteins, and the macrophage rests in the vessel wall. So it takes up all these lipoproteins that are carbonylated or glycated or oxidized and to form a foam cell, which is the basis for atherogenesis. Again, this is HDL becoming not cardioprotective, but a target to form atherosclerosis. And this is a gross picture of what foamy cells look like in the vessel wall. So these streaks, fatty streaks, when it continues, will become real live plaques. So what are the possible therapeutic targets? Well, there are clinical trials that have been done using aminoguanidine to prevent advanced glycation end products, to block that. Actually, I think aminoguanidine would have been effective if it weren't for the side effects. So this trial was halted. Using calcification, preventing calcification, using cinecalcip, there was no improvement. Again, lowering lipids, there was no improvement. Even using antioxidants, there was no prevention of cardiovascular risk. So what to do? Well, probably the best thing that we could do right now is a kidney transplant. And when we look at kidney transplants, again, this is the dialysis population, this is the general population, this is the transplanted population. And you can see that risk lies between the dialysis and the general population, but it's very close to the general population. So right now, this is the best thing to do for someone with end-stage renal disease, is to get a kidney transplant in terms of preventing cardiovascular disease. However, having a kidney transplant doesn't come without risk. Some people develop, because of the immunosuppressive therapy, some people develop hyperlipidemia, some people develop hypertension or diabetes. So there you go. Those are the risk factors that will contribute, again, to atherosclerosis. So that's one of the problems with transplantation. You will develop, some of these people will have heart disease as a result of atherosclerosis. So what's left? So there is a group in California that's working on the bionic kidney. So I don't know to what extent this will happen sometime in the future. So, but as a result of this, or what we have done, we're actually really sort of stuck for how to prevent heart failure and heart disease and kidney failure, but aside from using a transplant. So in summary, uremia-associated cardiovascular disease is caused by multiple factors. Protein modification is a major factor in uremia-associated cardiovascular disease. So it's not a lipid problem, it's a lipoprotein or modified lipoprotein problem. So we're just, unfortunately, at the beginning. So.
Very nice. Any questions for Dr. Brown? Any questions? You have your hands up.
Yep.
Thank you, Dr. Brown. Can you connect this with the previous talk? It sounds like how do you go from what, you did refer to some genetic differences. Are there other factors? I think we heard a lot about stress and as a function of racism acting over a lifetime. How does that play out in terms of
Okay.
lipids and cardiovascular?
Well, you know, there are people who have APOL1, and there's a lot of APOL1 variant, and there's a lot of research going on now in various registries that are being connected. So it is a real problem. You know, it's sort of like that gene was like the sickle gene. You know, it protected the West Africans from sleeping sickness. Okay, so that trickles in African Americans. So we have that ability. Not all of us, but some of us. And if you have two copies, that predispose you at risk for developing, if you happen to be infected by the HIV virus, to developing kidney failure. Or if you have hypertension, it may make the hypertension worse. So that's just one small part of it. The other part is the environmental and the social determinants. So it's additive to that just compounds the problem. But it's all connected.
Okay, thank you very much, Dr. Brown.